Thank you very much, Vasily. Thank you for the opportunity to present, for the invitation. It is always a big pleasure for me. And I especially wish to thank you because the topic you suggested, I don't know if you were aware about that. It was a part of my postdoc while in Paris many years ago. So I had the chance to go over the publications, and it's a lot of fun. And I hope that you like the presentation. And so over the next about 20 minutes, I think, I will try to give you an overview about this topic, the effects of the metabolic syndrome on the arterial system. And of course, I'm not going to talk about the whole arterial system. This is the cardiovascular model, how it looked like, at least when the group of Guyton many years ago tried to make a map of it. And now the same group in the same laboratory without Guyton, of course, have created something like that. So, of course, I'm not going to speak about the effect of the metabolic syndrome in each part of the cardiovascular system, but I'm going to focus on what is actually my research topic, and this is, as some of you know, the arterial stiffening and the arteriosclerosis. So I'm going to talk about that. But before talking about the effect of the metabolic syndrome on the arterial stiffening and the other parameters that are related to that, please allow me to give a short overview because it is absolutely necessary to be aware of what we are talking about, so you will better understand the differences that we have when talking about metabolic syndrome. So most of the effects of the arterial stiffening take place in all the organs, the brain, the heart, and the kidney, and so on. So we are going to touch on some of these topics, but of course not all of them. And to start with, I have to clarify to those that are not very familiar that we're not talking about atherosclerosis and atheromatosis, but we're talking about arteriosclerosis. It's as they say here in this very nice publication by Ian Wilson, Carmel McHenry, and John Cockcroft from Cambridge, that they are guilty by association, meaning that the pathophysiology and the pathogenesis is quite different, but of course they share some common mechanism and factors. So please keep in mind that we're talking about stiffening of the arteries, and stiffening, of course, and elasticity is vice versa. So we're talking about the ability of the artery to accommodate volume in the unit of pressure. So each artery has quite distinct ability, quite distinct coefficient of elasticity. And you see that even this is not linear for all the pressure, for the pressure load. It depends on the pressure load that the artery will have to accommodate. And of course, we know that this is mainly, but not only, based on the composition of elastin and collagen within the arterial wall. And this is why the aorta, as you see here, the thoracic aorta is very elastic, a lot of elastin and less collagen. And as we go down to the peripheral arteries, and the percentage of collagen increases. So there is a stiffness gradient within the aorta and within the arterial tree. So keep in mind that within the arterial tree, there is a stiffness gradient, and this is the pulse wave velocity that we measure in order to quantify the arterial stiffness. So you see that as we go down to the less elastic arteries, the pulse wave velocity within our body increases. So this is very essential. So mostly we talk about the aorta and elasticity of the aorta, but you see that it's important to keep in mind that other arteries also have elastic properties that are a little bit less modifiable. And the main pathophysiological and physiological effect of the arterial elasticity is described by this very well-known Wilkinson model. And very briefly, I will summarize that when we have elastic arteries, then the systolic blood pressure is kept low and the diastolic is kept a little bit higher. And the opposite takes place when we have arterial stiffening, meaning that the systolic blood pressure increases and the diastolic blood pressure decreases and the systolic increases. So the pulse pressure, the pulsatility will increase, and this has detrimental effects for the arterial system downwards. So this is the main, but not the only effect. And the higher the elasticity, the higher the stiffness, the higher the pulse wave velocity. So this is the basic rule in order to follow the presentation. When you see higher pulse wave velocity, then it means that the system and that we're talking about is more stiffened. But what we sometimes miss to discuss, and it is very crucial for the presentation today, is that the arterial stiffening is not only related and has a consequence, the increase in the pulsatility, which is very clear here in the picture. Normal stiffness, lower pulsatility, lower systolic blood pressure, a little bit higher diastolic, but in higher stiffness, very increased systolic and a little bit lower diastolic. So it's not only about the pulsatility, but you can see here that there is this arrow, meaning that here it is where the wave reflected from the peripheral artery is sum up at the level of the aorta. So we have to identify and to recognize that there are so many different waves reflected from the lower body or from the upper body that return to the heart. And when we have stiffer arterial system and stiffer arteries, then this wave reflected is summed up in a way that increases enormously the systolic afterload. So this is a very cardinal effect. If I wish to summarize, then let's say the higher the pulse wave velocity, the higher the wave reflections, but this is usually, and you will see the big difference in the metabolic syndrome. So as we are getting older and older, this is the well-known Framingham study published in the Franklin Circulation from Franklin many decades ago. And you see that no matter what is your age, the mean arterial pressure will increase, the diastolic will start to decrease at the level of 55 to 60 years of age, and the systolic blood pressure will increase again at this age point, 55 to 60. And here is the pulse pressure that increase in a very abrupt way. And actually, it is the same figure, the pulse pressure, it is the same, it's a photograph of the increase in the pulse wave velocity. So it is directly effect of the increase in pulse wave velocity. This is increase in pulse wave velocity. That was increase in pulse pressure during the aging. And I will finish the small introduction about this physiology of the system with a few more slides that are very crucial. It's not only so about the isolated systolic hypertension, which is a direct effect of stiffening, and you see that the black box here, it is the percentage of this hypertension phenotype when we are above the 70, 80 years of age, again from the very big enhanced cohort from the United States. And of course, when we get older, you know that most of us will have this isolated systolic hypertension. But we know very, very well that the higher the stiffness, the worse the cardiovascular outcomes. And this is very, very well presented for many decades now. And we have so many studies and meta-analysis. This is the best one showing clearly that when we have a higher stiffness, then the cardiovascular risk is very high, no matter what is the risk regarding the heart or the stroke, it's very, very high. And this is exactly the reason that we use the pulse wave velocity to reclassify the cardiovascular risk. This is the NRI, the number that is reclassified in let's say 100 of subjects. In 5 or 10 years, you see that 12 out of the 100 or 8 out of the 100. And here in intermediate risk, almost 25 of the 100 will be reclassified to the correct cardiovascular disease risk if we know the stiffening of the aorta. So it's a very important biomarker, and that's why we have many indications to use it in the clinical practice. And this is the last part of the physiology that I have to clearly discuss before going to the effect of the metabolic syndrome, is that due to the stiffness gradient that I was talking before, we know very well, and this is known for more than 80 years now, and this is invasive data, that when we go from the ascending aorta to the lower arteries, the systolic pressure within our system will increase and the diastolic pressure will remain constant. So it means that within our system, the aortic systolic pressure and the brachial systolic pressure that we measure, it's quite different. And we know that for many years. And this is a result of stiffness gradient and wave reflections. And now, of course, we have normal values, and we know that especially in the young population, the amplification, that is the difference between the aorta and the brachial artery regarding the pulse pressure or the systolic blood pressure, is quite enormous, even 30 millimeters of mercury. So this is a very big challenge, how to treat and how to classify the risk that is associated with the brachial blood pressure. And this is a case of a very young person, age 19 years of age. This is the arterial radial pressure, and this is the aortic pressure, and you see how big it is, amplification, the difference between the two segments of the arterial body in the same young population. So we are coming to a position to identify new phenotypes, and this is what we did more than 8 years ago in almost 2,000 adults at that time. And we identified new phenotypes based on both brachial and the systolic blood pressure. And we know now, and I will show you more data in the upcoming 2 slides, that when you have normal brachial systolic pressure but abnormal aortic systolic blood pressure, then this phenotype that right here or right here or right here is characterized with carotid damage, with carotid hypertrophy, and is almost even worse than having blood pressure in both brachial and systolic blood pressure. On the contrary, we have only brachial systolic blood pressure but normal aortic systolic blood pressure, then the probability to have carotid damage is not that low. So we have started to identify new phenotypes that characterize maybe better the blood pressure associated risk when we know both the brachial and the aortic pressure. And this is a very recent abstract in the previous ESH meeting, using 24-hour data from the SAFAR study, showing that this phenotype with aortic systolic isolated hypertension is not something to neglect, is almost sometimes quite high, around 10%. And again, here you see that it is 2.5 more probability of having carotid damage than having normal blood pressure at the brachial artery and the aorta, and very much higher probability of having hypertrophy of the heart. So the message is clear, and it is even clearer when you see this very important publication a few years ago from the group of Stassen, that when you have increased aortic blood pressure, even if you have normal brachial blood pressure, then you are in very high risk. And this is the line here that it is hidden within another line that is concordant hypertension, meaning that the risk of to die is very high when you have only aortic blood pressure high, even in the presence of normal brachial systolic blood pressure, and it's equal to those having both brachial and aortic systolic blood pressure elevated. So this is important. And so what is the difference that we have in the metabolic syndrome? And I will start discussing about that right now. This is the microcirculation in the presence of increased pulsatility and how it tries to actually damage the microcirculation. And we know very well that this is a problem not only for the heart, but now you see that we have many papers and meta-analysis suggesting that this also leads to cognitive impairment. And this is very well known from studies of the brain, the white matter hyperintensity, the microbleeds, the cerebral infarcts are higher in the presence of increased pulse wave velocity. And there are so many different ways that this takes place through the aortic stiffenings, the increased variability of the pressure, the increased flow and pressure that goes in the microcirculation, the prone of the atherosclerotic plaques to rupture, and even the thrombosis that can be initiated in the presence of their increased arterial stiffness. So we have data about stroke, about decline, of cognitive decline, but this is not all. When the microcirculation is under danger, then it fights back. And when it fights back, it means that it tries to push away the energy of the pulsatility, so it generates more pressure wave reflections that go back to the heart. And this is our recent meta-analysis showing that for one standard deviation of increase in pressure wave reflections, then you have 25 grams per meter square increased LV mass, and this is almost double CVD risk in the presence of increased wave reflections coming back to the heart. So it is very clear that we need to know not only the brachial pressure, but the aortic pressure. We need to know the pulse wave velocity, the stiffness, and maybe we need to know also the wave reflections in order to understand the risk in the whole body and the whole organs, the heart and about the heart failure and so on. And the last crucial about the physiology is that as we are getting older, the stiffness gradient is not constant within the arterial system, because you see here that the aorta is continuously getting stiffening and very abruptly, but on the contrary, the brachial stiffness is not so increased. So there is a point in our life, and this is a crucial point, where the aortic elasticity is higher than the brachial elasticity. And this actually means that the wave reflections at this time of the life period will change. And this is the attenuation theory of the wave reflections, meaning that when the stiffness gradient changes within the arterial body, then this let's say, protective mechanism for the microcirculation does not take place anymore. You can find all this data in the brief review we published in JACC several years ago. So it is important for us to know stiffness. It is important to know wave reflections. This is data from the Protogerou study we published a long time ago. And those who are going to have more cardiovascular events is those who have higher stiffness and higher wave reflections. This is very clear from this analysis. Combination of high stiffness and high wave reflections is associated with higher incidence of cardiovascular disease, but this is true in a population that is really very old and very frail. On the contrary, in recent analysis from Anther Stroke Registry, this is the data from a PhD student from our group, shows quite the opposite, that when you have very high pulse wave velocity but low wave reflections, and this is this group, then this group will have more events. And what type of events? Mainly from stroke events, meaning that when you have very low wave reflections, then the microcirculation of the brain is probably not very well protected. So far, this is what we know. And what is also important is that a very big part of the stiffening is genetically predetermined. So this very important study that was published 4 years ago from these two very big cohorts clearly stated that almost 60% of the variability of the arterial stiffening is genetically determined. And this is quite the opposite story, what happens in the peripheral vasculature, in the peripheral resistance. So pulse wave velocity is genetically determined, but still you will see here that there is a lot of room in the westernized population to accelerate this aging and to lead to early vascular aging. So although we have knowledge about the genetics, it seems that there is 40% of the arterial aging that can be inflicted by the way we live. And this is where the metabolic syndrome and the obesity will take place, and of course, the insulin resistance. So what about the early vascular aging? And this is where the obesity and the metabolic syndrome will take place. We know very well that this population has increased arterial hypertension, but what I will show you in the next few presentations, the next few papers, is that they have very specific pathogenetic mechanisms that are related to the wave reflections and the amplification within the arterial bed. Of course, this is due to comorbidities, and the risk that is increased in this population is partly related to what I'm going to show in the few slides. What is very well discussed is, and this is the publication from the president, from Vasilis Kotsis and the working group a few years ago, showing that the high cardiac output is one of the cardinal reasons for increased hypertension in the obese populations. And what also we know is that this population, and this is a study we did many years ago when I was in Paris, is that indeed, when you are in the presence of metabolic syndrome, then you have increased arterial stiffening. This is a population with more than 1,200 subjects. Most of them, the bigger parameter to classify them as with metabolic syndrome is the fact that they have hypertension and central obesity, but also insulin resistance, and as you see here from the hyperfasting glucose. And the main findings at that time were that males had slightly increased pulse wave velocity, but mainly females had increased arterial stiffening of the aorta. What is quite different, what would be expected at that time, is that the wave reflections in the presence of increased arterial stiffness are not increased in males, and even in females, you see clearly here that the augmentation index, which is the index of wave reflections, is rather lower than higher than it would be associated with pulse wave velocity. And this also comes together with the fact that the heart rate and the autonomic nervous system is activated in the presence of the metabolic system. So one very crucial difference in the systemic changes that take place in the presence of metabolic syndrome is, first of all, that we have difference between males and females, and secondly, that in presence of metabolic syndrome, there is rather an attenuation of the wave reflections. And this is a big question whether this is good for the heart and maybe worse for the peripheral circulation, a question that remains until now rather unanswered. Here you see that the pulse wave velocity remains a very good predictor of risk, both in the presence of metabolic syndrome and the absence of metabolic syndrome. But on the contrary, the wave reflections in the presence of metabolic syndrome in males quite still predict the cardiovascular risk, but in females, the attenuated wave reflections do not have any predicting values, and it is clearly a dissociation between the wave reflections and the arterial stiffening. At that time, also, we studied the amplification, and it was very also strange at the time to see that the amplification was increased in the presence of metabolic syndrome, but as we saw in the next slides, it was due to the increased heart rate and the autonomic nervous system that was accelerated in the presence probably of obesity and the attenuation of the wave reflections in subsequent metabolic syndrome, and especially in females. So the conclusion at that time was that in treated hypertensive subjects with metabolic syndrome, the amplification is increased, probably due to increased heart rate, although they will have higher arterial stiffness, but lower pressure wave reflections. So something that looks like that we have a system that is getting older, but still there is something that wants to stay young, and this is amplification that looks much like the age of a young person. The question at the time was also, is this only a feature of the metabolic syndrome? And we did an analysis at that time of the literature, and we clearly showed that it's not only the metabolic syndrome, but early diabetes, even acute inflammation, as shown by our friend Babis Vlachopoulos, and even the beta-adrenergic stimulation was a parameter that gave the same pattern, that is dissociation between stiffness and wave reflection, keeping in mind, therefore, that beta-adrenergic stimulation, or the contrary, the beta blockade, may be something to keep in mind in patients with metabolic syndrome. And this is not only that, even in other situations, you see here the Adamadiadis-Bercet disease, a disease with inflammation and also increased heart rate, is also characterized with reduced pressure wave reflections, although we have increased pulse wave velocity, that is increased aortic stiffness. So it is clear, and this is our view until today, that the brachial blood pressure is not the most reliable method to assess cardiovascular disease risk. And this is particularly true for the metabolic syndrome because of the presence of amplification. And in this next publication, we clearly have shown that this is driven mostly by the central obesity. You see that the waist circumference below and above 102 is the parameter that classifies the population in low and high amplification or in low and high heart rate. So it's clearly that there is a stimulation of the autonomic nervous system in the presence of obesity. And I don't want to spend too much time, but there are other technical issues to consider that concern the interaction between heart rate, arterial stiffening, and wave reflections that are quite important in the metabolic syndrome. So this is our last slide regarding a metabolic syndrome. This is a review paper with novel data that we presented at that time in 2013. Together with the group of from the Paris, of course, with Michel Safar. And I think this slide tells everything. You see here, the blue line is the women, and the red line are the men. This is with metabolic syndrome. This are without metabolic syndrome. It's very clear that the metabolic syndrome affects mainly the females and not the males, in a way that even at lower ages, the females with metabolic syndrome have already worse pulse pressure, pulsatility than even the male with the same age. So this is due to increased stiffness, but lower pressure wave reflections. And this is once more the same story from another population in the same paper we presented. So to come to some conclusions, I think that we have come to a position to understand that when we want to treat cardiovascular risk in the presence of hypertension, and specifically in the presence of metabolic syndrome or diabetes mellitus, we have not only to take into consideration the classical knowledge, but we definitely need to know stiffness and wave reflections and central blood pressure. And there are more data, of course, that I cannot share with you because we have not so many time, but the story is always more or less the same in the more recent years. So I will finish up by saying that yes, we have increased prevalence of hypertension, but in the presence of metabolic syndrome, we have a very distinct pattern, high stiffness with lower pressure wave reflections leading to increased amplification. And there is a crucial role of heart rate. And although we do not have RCT trials and we do not know if it is true or not, we have to be very, very careful with the clinical application of beta blockade, especially in the presence of metabolic syndrome, because this could slow down heart rate and completely change the amplification, which seems to be rather a favorite pattern in the presence of metabolic syndrome. So I believe strongly that in the years to come, in order to answer questions like that, the isolated systolic hypertension, then we definitely will incorporate central hemodynamics in our practice. We will definitely go to the direction of arterial stiffness mapping, and especially in the presence of metabolic syndrome, it is needed. We will have to have more extensive phenotyping of the hypertension based on both central and aortic blood pressure. And this is, for me, a very crucial publication I saw before from the IDACARS study, showing that in the presence of aortic systolic blood pressure, then the risk is quite high. And I will finish here by dedicating this presentation to my mentor who passed away a few months ago, Michel Safar. Thank you very, very much.